I would like to ask Professor Catherine Owen, and I have to say that Catherine and the group from Oxford are the world leaders in the research on biomarkers in MODY, and this is edge-cutting research, and I think that this is going to be a fascinating talk.
Thank you for that very generous introduction. I hope I don't disappoint you. So I'd like to switch back to talking mostly about MODY now. And you'll recall that I put up this slide yesterday talking about the different methods we might use to diagnose monogenic diabetes. And today I'm going to concentrate on whether we can define specific biomarkers for MODY subtypes which could improve selection of cases prior to genetic screening. So why do we need new diagnostic tools for MODY? Well, one of the greatest barriers to genetic testing at the moment is the cost of arranging these tests. And certainly in the UK, each MODY gene that we request costs about €400. I mean, I guess the cost is similar here. And we may have to sequence 2 or 3 of these genes. So if we could find a non-genetic biomarker that was much cheaper, this would mean that you could pick out the people at highest chance of having a MODY mutation and cut down on the amount of people who were sequenced. Just take a minute to think about what we might want in a biomarker. So we could show that there is a statistically significant difference in blood levels of a certain marker between 2 different groups of diabetic patients. But this needs to be of clinical significance as well, so there's no point showing that something alters triglycerides by 0.01 millimoles per litre. It's not clinically significant. So we've got to think about that as well as our statistical significance. Of course, you want the marker to be highly sensitive so that you can detect most cases. And you also want it to be highly specific so that you exclude most of your non-cases from screening. And then you want a high discriminative accuracy of the test to discriminate between the 2 types of diabetes that you're trying to discriminate between. So if we look at a screening test, if we've got a biomarker, just call it biomarker A, that, if it's normally distributed, that might be its distribution in your controls, and this might be its distribution in cases. And you can see that there the blood levels are quite nicely separated. Of course, what you might see is that there isn't very good separation between your cases and controls. And what you're more likely to see in clinical practice is something more like this, where there's some overlap between cases and controls, but still a reasonable separation. And if you took a threshold level of your screening test somewhere like that, you can see that most of your cases fall above the threshold, so the test's highly sensitive. But you've still got quite a lot of controls that will test positive, so it's low specificity. And this is the sort of opposite position. Here, most of your controls are not included, but you lose sensitivity because not all your cases are included. So there's always this, whenever you design a test for any reason, there's always this sort of trade-off between sensitivity and specificity. And what we might see is that you put your diagnostic threshold somewhere here, so you get a reasonable sensitivity and a reasonable specificity. And just to remind you that your cases that are picked up by the test are the true positives. Your controls that are picked up by the test are your false positives. Your cases that are missed by the test are your true negatives. And your controls that are correctly identified by or correctly missed by the test are the false negatives. So that gives us sensitivity as true positive divided by true positive plus false positive. Specificity true negative divided by true negative plus false negative. We then go on to think what can we use to look at the discriminative accuracy of a test, and what's often used is receiver-operated characteristic curve analysis. And this is a way of plotting the true positive rate on the y-axis against the true negative rate on the x-axis. And if you have a perfect discrimination between two tests, you'll get a curve that looks like that. Whereas if your test is no good at all, you get a line that looks like that, and that means that your test is just as good as tossing a coin. And we measure the area under the receiver-operated characteristic curve. And if you're looking at screening tests, an area under the curve of greater than 80% is considered to be a good test, and commonly used tests such as mammography achieve this kind of level. And if you have an area under the curve between 70 and 80% is a fair test, but less than 70% we consider it was poor or useless as discriminating between your two disease types. So to go on to talk specifically about biomarkers in MODY, so our aim, as I said, would be to derive novel biochemical tests to aid screening for genetic subtypes. And concentrating specifically on the transcription factor mutations, we might look at the non-pancreatic features of those, because those are the things that are unique to the transcription factor mutations against type 1 or type 2 diabetes. So we mentioned yesterday that HNF1 alpha is expressed in the liver, kidney, gut and pancreas. And so we could go and derive our candidates from animal models such as the knockout mouse. We could look at bioinformatics, and we could of course look at a human phenotype. So if we consider some of the features of the HNF1 alpha knockout mouse. So this has as you might be able to tell from the name of the gene, this has a very large liver phenotype, and there's alterations in absolutely hundreds of genes in the liver, in the knockout mouse. And some of the common things we see are defects in bile acid metabolism, a lot of alterations in serum amino acids. We see lipid abnormalities or differences, and we see raised liver enzymes, and actually many more. There's also a renal phenotype, and in the knockout mouse, it has a severe renal phenotype of Fanconi syndrome with urinary loss of glucose, amino acid, and phosphate, such that the mouse wastes away because it loses so much glucose in the urine. There's a beta cell phenotype, so decreased insulin secretion and diabetes. And in one of the knockout mouses, there were growth defects, infertility, and early death. So whenever we go from mouse to man, we have to think, how well does the mouse resemble the human model? So if we look at our HNF1 alpha knockout human, obviously we have a diabetes, the insulin secretory defect. As we mentioned yesterday, there's a low renal threshold for glucose, which leads to glycosuria. There's some argument about whether people with HNF1 alpha MODY have got raised HDL cholesterol levels. Perhaps not. But on the whole, allowing for the fact that these people have diabetes, there's normal growth, fertility and lifespan. So you can see that the mouse model is not such a good mimic of the human model. So we have to take that into account when we're thinking about different candidates. So one early candidate biomarker derived from the knockout mouse was apolipoprotein M, or ApoM. So this is a constituent of HDL, and it's under transcriptional regulation by HNF1 alpha. And if you look in the knockout mouse, the expression of ApoM is reduced by about 25 times. So the other advantage of it is it's something we can measure in the serum. So it was a good candidate. And an initial study from Marcus Stoffel's group, which started with animal work but also included some human work, but only 9 cases of HNF1 alpha MODY, showed that ApoM levels were around a third lower in HNF1 alpha than in non-diabetic cases or individuals with HNF4 alpha MODY. And that was published a few years ago. And I think the difficulties over the availability of the assay meant that this wasn't then looked at for another few years. But then there have been some larger replication studies from Maszek's group, from the Swedish group, and more recently we've tried to put the data together and done a European study which is not yet published. And what we see is that although ApoM levels in HNF1 alpha are lower than in healthy controls, ApoM levels are also reduced in type 2 diabetes, and that's probably because of the effects of chronic inflammation. So that means it's actually not a very good marker for what we wanted to do, which is differentiate subgroups of diabetes. So then another example from both the mouse and the human model was the presence of glycosuria, which is quite a marked feature of HNF1 alpha MODY. And this is caused by reduced expression in HNF1 alpha mutations of the low affinity high capacity glucose cotransporter on the renal tubules. So these people, normally this carrier transporter reabsorbs glucose in the proximal tubule, but if you have a defect, you get more loss of glucose in the urine and low renal threshold. And as we discussed yesterday, postprandial glycosuria is used clinically to monitor hyperglycemia in at-risk relatives who haven't had genetic testing. So the question arose, can urine glucose be used to discriminate HNF1 alpha MODY from type 2? And this was a very astute and clever paper from co-chairman looking at this substance called 1,5-anhydroglucidol. So I hadn't really heard of this, so I'll explain to you what it is. And this is a monosaccharide, which is structurally similar to glucose. So you can see if that's glucose at the top, and 1,5-AG is just differs by this difference here. And it's non-metabolized monosaccharide, and we take it in our diet and we excrete it renally. And so you sort of get a balance of it in the body. And what's interesting about this is the renal handling, because in the proximal kidney tubule, it's reabsorbed by a monosaccharide common transport system, so that under normal circumstances, you get a sort of balance between the reabsorption and the dietary input. Now, glucose, although it has other carriers, transport systems in the kidney, it can also be picked up by this monosaccharide carrier. So when you get glucose in the urine, or glycosuria, you actually get competition at this carrier. So some glucose is reabsorbed by the carrier, and 1,5-AG is then actually lost into the urine. So if you have glycosuria, your serum levels of 1,5-AG fall. And this is actually marketed as a diabetes test, which is used in the States and Japan, to use glycosuria to measure diabetes control. But the hypothesis in this situation was that if you have lower 1,5-AG level, you should have lower 1,5-AG levels in HNF1 alpha MODY due to the low renal threshold. And could this be used as a sort of diagnostic test? So, in fact, that was what was found, that HNF1 alpha MODY had about half the serum level of 1,5-AG compared to type 2. And that best diagnostic discrimination was in a limited HbA1c range between 6.5 and 9%. And that gave a good area under the ROC curve in the initial test set of nearly 0.9. So we went on to try and replicate this, because if you can't think of something for the first time, try and copy it. What we did was added a wider range of diabetes subtypes, including type 1 and LADA and glucokinase MODY, as well as type 2. And to try and get some further evaluation of the performance of this as a test.